Hi everyone, my name is Jeanette Tannafranca, and today I am going to present my DNP project, Personal Safety Survey, a self-assessment tool for registered nurses in an ambulatory care setting using a human factors approach. I would like to take a few moments to thank my committee chair, Dr. Passini, and my committee members, Dr. Whalen and Kat Wagner, throughout my DNP journey for their support and encouragement. Thank you so much. The optimal performance of nurses in healthcare plays a critical role in quality of care and patient safety. Human factors such as fatigue, lack of sleep, stressors, distractions can affect performance and has been identified as causes and contributing factors for safety events, such as in the case of medication errors and near misses. Nurses are expected to remain alert, efficient, and maintain high performance despite all these human factors. There are a few performance tools, checklists that exist in the literature that assess personal performance, health status, or fitness to perform related to human factors and limitations for RNs in an ambulatory care setting. The Institute of Medicine report, To Err is Human, Building a Safer Health System, estimated that 98,000 deaths as a result of medical errors. In 2013, John James used a trigger tool to identify preventable adverse events by reviewing medical results and estimated that the number was actually almost 400,000 deaths associated with preventable harm. 4 out of every 10 patients are harmed in primary and outpatient health care. The IOM also reported that human factors and system approaches were recognized as critical implications for safety across all healthcare domains. Healthcare workers, especially nurses, are prone to fast-paced, complex environments that may lead to errors. Nurses were also more likely to report medication errors when they worked more than 4 hours of overtime or more than 40 hours per week. Fatigued staff are significantly more prone to human errors, and nurses are at risk when they're interrupted or distracted and make an error. Each interruption was associated with a 12% increase in procedure failures and 12% increase in clinical errors. How can we apply a human factors approach to improve patient safety? We can design work processes to take into account of our human limitations. We can also utilize checklists as a strategy for improvement from a human factors perspective. Checklists provide a method to standardize care, improve communication, and have had a positive impact on patient safety. Some examples of clinical safety checklists include central line insertion, standard communication using SBAR, procedural and diagnostic checklists. There are several types of checklists, but few that explore and assess the personal safety status of the healthcare provider. There are nursing performance tools in the literature that evaluate nursing work performance. The Nurse Competence Scale assesses knowledge, skills, attitudes, and situations. The 6-dimensional scale of nursing performance measures leadership, critical care, and planning. The Taiwan Nurse Stress Checklist measures competence and work concerns. The General Health Status Checklist looks at self-perceived health status. The Nursing Performance Instrument looks at behaviors practiced by nurses when providing care. Most of these checklists were focused on the acute care setting and competencies. Very few of the self-assessment and nursing performance tool were done in an ambulatory care setting and assessment of one's personal safety status. There are very few studies that explore a checklist to assess the personal safety status of the healthcare provider. Health professionals should consider their own assessment of their ability to perform correctly a personal responsibility. The I'm Safe checklist was used in aviation and modified for team steps. The I'm Safe checklist does not have a standard measurement or scoring instrument and is used as part of situation monitoring. Due to these gaps in the literature, I decided to explore the use of a personal safe survey by adding a measuring method and using it in the ambulatory care nursing setting. The checklist would be used before going to work and assess the personal safe status of a registered nurse. This brings me to my DNP project. The aim of this project is to explore the use of a self-assessment tool, the Personal Safety Survey, using a human factors approach with RNs in an ambulatory care setting. The human factors approach has been shown to improve patient safety and prevent errors. Human factors such as fatigue and distractions contribute to adverse events. Safety tools such as checklists can be beneficial in a clinical setting. Nursing performance is an important measure of patient safety, and changes in their performance can be detrimental to the care of a patient. My clinical questions for my project include: what human factors do RNs identify when using the Personal Safety Survey? Do the registered nurses assess that using the Personal Safety Survey will determine if they are fit to practice safe care? How does the Personal Safety Survey results compare to contributing factors that are being reported in Radicalogic, which is our reporting tool in the healthcare organization? And what strategies are identified by RNs that will support their work environment? The theoretical framework that I chose for my project was the Systems Engineering Initiative for Patient Safety 2.0 model. It's developed from a human factors perspective for patient safety. The key characteristics include the work system and its interacting elements, such as the RN, his or her work environment, his or her self-assessment using the Personal Safety Survey, care processes, and feedback loop. The project design included a cross-sectional descriptive design in form of an electronic survey. Quantitative and qualitative data was collected. The target audience were ambulatory registered nurses. The project was approved by the IRB at the university as well as the healthcare organization. Data was collected using the instrument, which was the Personal Safety Survey. The Personal Safety Survey consisted of 3 sections. The first section were demographic questions, the second section was the Personal Safety Survey tool, and the third section were follow-up questions. The project was presented to nursing leadership and RNs. The instructions were given to those that participated, and the instructions were to complete the survey prior to going to work at least 1 to 2 hours before the start of their shift, and to take the survey only once during the 2-week time frame. Descriptive statistics were used to examine the variables to sample Wilcoxon test, chi-squared, overall Kruskal-Wallis test, and pairwise comparison. A qualitative analysis was conducted for follow-up questions number 4 and number 5. Analyses required coding for the 5-point Likert scale for the Personal Safety Survey and the follow-up questions. So a number 1 was assigned to strongly agree, a number 2 was assigned to agree, a number 3 was assigned to neither, etc. Statistical significance was set at p-value of less than 0.5, and categories were combined due to small sample size, such as age groups and job title. 83 nurses completed the survey. 89% were female, 86% were RN staff, 96% worked day shift, 95% were full-time. 55% had a bachelor's degree, 23% had an associate's degree, 12% had a diploma, and 9% had a master's degree. 34% were between the ages of 45 and 54, 26% were between 55 and 64, 18% were between 25 and 34, as well as 35 to 44. 2% were between 18 to 24, and 1% was over 65. I will go through the results and then follow up with discussion. Question number 7 on the Personal Safety Survey was, I feel fit, ready, and able to go to work and perform safe care. This tests the first 6 questions on the survey and 3 questions of the follow-up questions. It resulted in 2 groups, the fit group and the not fit group. The relationship of fit status and variables was examined. There were significant results with Personal Safety Survey question number 1 about illness, number 5, fatigue, number 6, environment. The results show that the fit group feels more strongly, that they do not feel so ill, that they are less fatigued, and that the environment is safe and enables them to perform safe care. Next, analysis was conducted to examine the relationship of the fit RNs and the demographic variables. A series of chi-squared Fisher's exact test was conducted to examine the relationship of those RNs that were considered fit and the demographic variables. The manager, mid-level provider, and educator groups were combined due to the small sample size. The part-time, contingent, and float groups were combined due to the small sample size. There were no significant findings noted. Next, analysis of covariates in Table 8, job title, Table 9, age, Table 11, job status. The demographic variables were then examined to see if there was an association with responses for the 10 questions of the personal safety survey. No significant findings. An overall Kruskal-Wallis test was followed up with pairwise comparisons using a 2-sample Wilcoxon test was used. The relationship between age and the personal safety survey questions were examined, and there were no significant findings. Next, pairwise comparison for age was examined. The results were significant for personal safety survey question number 2, which was, I am taking medication that impairs my ability to perform safe care, and the RNs in the 45 to 54 age group. This group strongly disagreed that they are taking medication that impairs their ability to perform safe care. The relationship between job status and the personal safety survey questions was examined, and there were no significant findings. Pairwise comparison was conducted to examine the relationships between the personal safety survey questions and the educational degree of the nurse. The findings will be discussed in the following slides. The fit group agreed more strongly that they do not feel so ill, they are less fatigued, and that the environment is safe and enables them to perform safe care. The 45 to 54-year-old group disagreed more strongly that they are taking medication that impairs their ability to perform safe care. The BSN group disagreed more strongly that they are taking medication that impairs their ability to perform safe care compared to the ADN group. The BSN group agreed more strongly that they feel more fit compared to Diploma and ADN groups. The Diploma and ADN groups feel fit as well, but not as uniformly as the BSN group. There was variation within groups regarding fit to perform, and perhaps the BSNs with more education were more aware of the benefits. The Diploma group agreed more strongly that they would use the personal safety survey more than the ADN and BSN group. The Diploma group agreed more strongly that they would encourage coworkers to use the personal safety survey than the ADN group. The MSN group agreed more strongly that they would encourage coworkers to use the personal safety survey than the ADN group. And the Diploma group agreed more strongly that they would want their healthcare provider to use the personal safety survey than the ADN group. The variance within the education groups was interesting, and I think the higher the education, the more knowledge and the more support they would provide. Yet it shows diploma nurses were in more support of using the survey. The findings support the notion that nurses are equipped with professional knowledge and health promotion and are better at managing their own health. Does more education, nursing or otherwise, equal more knowledge or classes in health promotion? The health status contributes to work performance, and perhaps the nurses were reluctant or hesitant to disclose the medications they were taking. How does age and medication affect one's ability to perform safe care? How does education and medication use affect one's ability to perform safe care? How does education affect one's fitness to perform safe care? How does education affect the use of the personal safety survey for self, coworkers, and perspective of patient? These are additional questions that come to mind when reviewing the results. The results for the 2 qualitative questions, have you done anything to mitigate any of the items mentioned in the personal safety survey, resulted in several themes of how the RNs managed stress, how they managed fatigue, and how they managed physical and emotional health. Many of the nurses described activities such as practicing yoga, walking, listening to music, prayer, as ways that they mitigate those following things. Some even call off when they feel that they are not fit, ready, or able to go to work. So it's interesting that even though the majority of RNs reported that they felt fit, ready, and able, they still described themes of stress, fatigue, and physical and emotional health and ways that they practice to mitigate some of those factors. Question number 5, what type of resources would you like your organization to provide for you so you can perform safe care? Demonstrated the following themes in terms of staffing, technology, manager involvement, education, and environment. So although the majority of RNs reported that they were fit to practice safe care, many nurses reported the need for additional resources in their work environment, which would allow them to perform safe care. The results indicated that further exploration is needed to obtain a better understanding in the areas of stress management and health maintenance and how organizations can provide these type of resources. For example, under staffing, one nurse suggested to create a resource team to assist staffing when an RN needs to call off. Under technology, one RN recommended a software that would help drive physical activity, such as reminding someone to stand up and stretch, or neck movement, deep breathing. Conducting a focus group could be informative as it would provide more context around the responses. Leadership involvement is key in providing change, resources, and support for the RNs in an ambulatory care setting. The RNs were described as fit and ready to perform safe care when they took the survey 1 to 2 hours before going to work. However, it appears when they arrive at work, they describe items that they need to be able to be safe and fit in their work environment. So it's interesting to see that result communicated through the survey. Radicalogic is a safety event reporting system used by the healthcare organization. A report was pulled up from January to October 2019 and showed there were 58 medication safety events reported for the D campus, the campus where the survey was conducted. There were 84 contributing factors on the report, which includes a human factors component such as fatigue, stress, multitasking, communication failure, and distraction. The report suggests a potential opportunity to explore how the use of the personal safety survey can impact medication safety events and improve patient safety in the ambulatory care setting. The report can be used as a springboard to open dialogue about identifying and preventing medication errors and other types of safety events with RNs. Nurse leaders, risk, quality, and the frontline nurses can initiate discussions and work towards solutions to prevent errors and improve patient safety. Limitations to my project include that the survey was provided to RNs that worked at the D campus location and worked mostly day shift. The RNs may be experiencing survey fatigue as the organization has issued many surveys in the past few months for employees. Self-selection bias. It's more likely that nurses that consider themselves safe chose to participate in the survey than non-safe nurses, which could have affected the results. Practical implications for the personal safety survey include that it can be used as a self-monitoring tool for ambulatory nurses to assess their fit-to-work status using a human factors approach. The personal safety survey contributes to the body of literature for ambulatory nursing and the use of personal safe checklists. The personal safety survey identified potential opportunities for organizations and leaders to monitor and improve the health status and environment for their nurses. Further exploration is needed, so I actually came up with a list of 10 or so additional inquiries to explore. Why are the nurses saying they are fit to practice before coming to work, yet when they come to work, they identify stressors and ways to mitigate those stressors? Nurse leaders need to understand how human factors can affect personal safety, which can affect patient outcomes and patient and employee safety. Can the personal safety survey improve patient outcomes and employee safety? Nurse educators need to understand that nurses have various educational backgrounds and may conceptualize patient safety in different ways. What types of strategies and methodologies can be considered for patient safety education? And how does the organizational culture play a role in patient safety? Can the personal safety survey be supported by a robust safety culture that includes human factors training, transparency, speaking up, and reporting of errors? Implications for organizational leaders. Most of the nurses assess that they are fit to work, yet cite reasons that their workplace environment is in need of resources and additional support. What changes from the time they leave to go to work to when they arrive at work? What are the barriers from the organization's perspective to provide a safer work environment? What ethical implications have been identified with a personal safety survey? Several ethical implications may include the right to be protected against discrimination when disclosing personal information, sharing of medical history and information. How transparent are the users of the personal safety survey in regard to the use of alcohol and drug question, for example? Optimal performance of nurses in healthcare settings plays a critical role in care quality and patient safety. Examining the use of the personal safety survey was an important introductory step to contribute towards body of knowledge for ambulatory care nursing and personal safety checklists. The findings suggest that there is support in using the personal safety survey in the ambulatory care setting by the nurses. Educators need to be aware that diploma, associate degree nurses, bachelor's prepared nurses, and master's prepared nursing graduates may conceptualize safety differently due to their educational programs and curriculums. Hospital leaders and organizations need to understand and respond to the physical and psychological health status needs of their nurses and their ability to perform safe care. I will close out my presentation with a quote from Lucian Leape. Human failures represent the greatest threat in healthcare, and acknowledging the probability of human error in patient safety may be the first step toward prevention and adoption of safe practices.